It's really my delight and honor to present Dr. Vitaly Napadow, who is the associate professor at Harvard Medical School, and he's based at the Martino Center for Biomedical Imaging at MGH. He's also the director for the Center of Integrative Pain Neuroimaging. Dr. Napadow's work in neuroimaging, particularly or especially around thinking about the mechanisms of acupuncture, have really paved the way in terms of our understanding of how acupuncture might be working, its effects in pain management, and I would say, he is really one of the leading authorities. So we decided we want to just go ahead and get started on time because there's a lot of a good material for us to really chew upon, and hopefully, and then we have some time at the end to really engage in some lively and intimate discussion. So, Dr. Napadow.
Yeah, thank you very much, Darshan, for that introduction, and I'll get right into it. So this work sort of represents a series of studies that we've been doing in the lab for a while to try to understand acupuncture mechanisms. So we know that acupuncture can be comprised of different components. There's the ritual that's associated with the procedure itself, with the intervention, and has to do with the history, the palpation, and all the elements that go into that. There's also the relaxation response, which is due to the needles that are in place after they're inserted and the patient that's lying on the table being treated. But there's also this important element of somatosensory stimulation, which is the fact that the needles are penetrating the skin, and there's a sensation that's associated with that. There's mechanoreceptors that are responding to that, and also electrical stimulation that's also enacted. And so it's this element that's then feeding up to the somatosensory cortex of the brain. And for this study, that's what we were focusing on. So a little bit about carpal tunnel syndrome. Carpal tunnel syndrome is a neuropathic pain disorder. It's a very common entrapment neuropathy at the wrist. And there's a vicious cycle that's associated with carpal tunnel syndrome. So that includes pressure inside of the carpal tunnel, which is, let me try to, do I have this? No. I do. Okay, so there's pressure inside of the carpal tunnel, which then produces ischemia and inflammation, and then damages the nerve microvasculature, producing exudative edema and fibrosis, which then cycles back, increasing the pressure inside of the carpal tunnel, all leading to pain and paresthesias in the fingers that are innervated by the median nerve, which are the first through the fourth digits. So the question is how can acupuncture break this cycle? So first, a little bit of definitions. So carpal tunnel syndrome, which is a model of neuroplasticity, we need to have a definition of neuroplasticity. So here, neuroplasticity is referred to from the Greek plastos, and the definition of neuroplasticity here is that the brain can modify both its structure and its function following changes within the body or external environment. This is sort of the definition given by the Society for Neuroscience, SFN. So interestingly, while most chronic pain disorders are anchored by subjective outcomes, so this is what we typically have to deal with, let's say if we're studying low back pain, is the patient is reporting how much pain they're in. This is a subjective outcome. And CTS is one of the few chronic pain disorders that actually has an accepted objective physiological marker of the disease, nerve conduction studies. So, and I think this is important because we've seen other studies investigating the placebo effects, such as this study by Wexler et al., which was published in the New England Journal, which found that objective outcomes, which in this case were asthma attacks, that were improved by albuterol were not improved by placebo disorders, whereas subjective outcomes, the subjective nature of these attacks, were improved by different types of placebos and equally to albuterol. And so I think this is an interesting sort of parallel to what we're seeing here in this chronic pain disorder. So nerve conduction studies is really an electromyographic procedure where we look at the impulse over the wrist. So we sort of stimulate at the area of the forearm, and the pickup is happening at the fingers distal to the wrist. And so the definitions of CTS are based on these nerve conduction studies. So mild and moderate CTS have to do with delayed sensory nerve conductions and also some delayed motor nerve conductions, whereas severe CTS is really having to do with loss of motor amplitudes and even muscle atrophy that you see in the thenar eminence. And so I think one thing I really want to make clear is that when we're investigating acupuncture procedures for CTS, we're really referring to mild and moderate CTS here, not the severe CTS, which is typically quickly sent over to the surgeons for surgery to avoid further damage. So the therapeutic options for CTS include surgery, which is, of course, a invasive procedure, but also non-invasive procedures such as steroid injections are used, splinting is used at night, for example, or even sometimes during the day, and acupuncture is also a viable alternative. So there have been a few studies of acupuncture for carpal tunnel syndrome. In this study, 4 weeks of steroids were compared to acupuncture, and acupuncture was found to be superior to steroid. These are oral steroids in terms of nerve conduction studies and also with 1-year follow-up. A different study, though, compared acupuncture to sham acupuncture and found no significant differences. In this case, this group didn't even assess nerve conduction studies. They took, and there's a lot of heterogeneity there because a lot of people think that they have carpal tunnel syndrome, but actually have normal nerve conduction studies, and those are referred to as RSI, or repetitive stress injury. And so typically, if you're enrolling, you'll get a mixture and potentially even more RSI patients than sort of explicit carpal tunnel syndrome patients. So that's an important distinction to make. And in this case, subjective outcomes were equal between Verum and sham acupuncture. So importantly, CTS, we know, doesn't just affect the wrist. There was a series of studies, evoked potential studies, dating back to the late 1990s and the early 2000s that found that there was amplification and altered evoked potentials all up the somatosensory chain in the spinal pickups, in the brainstem, and even in the parietal, in the cortex. And so these were kind of EEG studies, and they were sort of denied us for the work that we were doing with functional MRI. So we were the first group to use functional MRI to look at carpal tunnel syndrome as part of our study. And so this was the pilot study where we evaluated patients at baseline with clinical testing and functional MRI on 3 fingers. 2 of the fingers are innervated by the median nerve, that's the second and the third finger, whereas the ulnar nerve is innervated, whereas digit 5, the pinky, is innervated by the ulnar nerve. The patients were evaluated midway through with clinical testing, and then after 5 weeks of acupuncture, they returned again for clinical testing and functional MRI. This was compared to healthy adults. We had a small group of healthy adults which just experienced the clinical evaluations and functional MRI before and after a 5-week wait period to look at the stability of our objective brain-based outcomes. The protocol was a semi-individualized protocol that we used for acupuncture. It was mainly local acupoints, and everybody got electroacupuncture, sort of low frequency, low intensity electroacupuncture on PC7, which is right at the wrist, and triple warmer 5, and then other acupoints were chosen based on individual presentation. This was kind of our way to deal with the tension that exists between acupuncture, the clinical practice, and acupuncture research, where the researcher want to standardize everything, whereas in clinic, Of course, the acupuncturists want to choose individual points based on individual patient presentation, and so this was our way to kind of go halfway between the two. So what we found was that there was, first of all, improvement in subjective outcomes. This is the Boston Carpal Tunnel Syndrome questionnaire, and there was improvement both midway and after the acupuncture procedure. And also, there was improvement in nerve conduction studies, which is an objective outcome after the acupuncture. So here you see the red bars compared to the dark blue bars are the CTS patients compared to the healthy adults. And you can see not much of a difference before and after in the healthy adults between the weight, which is as you would expect. Whereas in the carpal tunnel syndrome patients, we did see statistically significant improvement after the 5 weeks of acupuncture. So the other thing we did is we looked at brain response and the location of this brain activity. So here we're mapping what's called somatotopy in the brain. And so somatotopy is this concept that different parts of the body are mapped onto the primary somatosensory cortex in different locations. And so this was first noted by a surgeon, Edgar Penfield, up in McGill University in Canada, who in the 1930s was doing experiments in epileptic patients, and these patients are awake. And so he would literally take an electrode, he would zap different parts of the primary somatosensory cortex and ask the patient where they felt that sensation. And by doing this procedure, he was able to map out the S1, or the primary somatosensory cortex in the brain. And so you can see that the hand is represented over here, and this is typically what we're going to be focusing on for carpal tunnel syndrome, but you also see the face, large areas. Large areas means large numbers of neurons, and that's completely mapping with the sensitivity of our body. We're much more sensitive, for example, on our tongue and on our face and on our hands than we are on our back, right? And so that's why there's this greater amount of territory that's given to those body areas. So we're again focusing here on the hands since we're dealing with carpal tunnel syndrome. And so with our functional MRI, we can non-invasively, we don't have to open up the skull, we don't have to open up the brain, we can non-invasively map stimulation in different body areas to their cortical representations in S1, primary somatosensory cortex. So this is the brain response for an individual in digit 2, digit 3, and digit 5. And you can see that as we go from digit 2 to digit 3 to digit 5, the activation is going up the gyrus. And this matches very nicely with what Penfield found as we go from thumb to index to middle to ring and to little finger in the hand. So the point here is that we can non-invasively assess the same type of somatotopy that Penfield was able to do with much more invasive techniques. And so what we found is that compared to healthy adults, patients with carpal tunnel syndrome have contracted representations, sort of a blurring of representations for the fingers that are innervated by the median nerve. So you can see digits 2 and digits 3 over here in the carpal tunnel syndrome patients compared to the nice separation in digits 2 and digits 3 in the healthy adults. So this was interesting. And then we also found that after acupuncture, and remember acupuncture is improving these subjective and objective findings at the wrist, we also see a larger separation after the acupuncture in the cortical representations of these fingers, digits 2 and digits 3. So here it was electrical stimulation on the fingers, which is a little bit different than what I'm going to show you in a bit for the second follow-up study. But here, yeah, it was just electrodes placed on the fingers. So our model for what's happening here is that the pain and paresthesias in carpal tunnel syndrome are leading to more frequent and abnormal nerve traffic to the brain, which then through disinhibitory processes leads to more extensive and wider digit representation. So there's a blurring that's happening. And the interesting thing is that it's not just more traffic due to the pain, but it's the nature of the traffic, and it's simultaneity of the signaling because these paresthesias that they're feeling are diffuse. They're spread out over multiple fingers. And because they're diffuse, there's now not a temporal break between when you feel a certain sensation from your second finger to your third finger, which is what sets up this somatotopy in the first place. Now it's simultaneous. And because it's simultaneous, there's something called Hebbian plasticity mechanisms, which then lead to a blurring of these representations. So it's less separated and blurred digit representations in S1. This is quite similar to what you see with a condition called syndactyly, and syndactyly is a webbing of multiple fingers. So for example, you can do this in a monkey model where you can take two fingers and you can literally sew them together into a webbed single digit. And after the animal is behaving for a little while with this syndactyly condition, you now get certain neurons in S1 that used to be responding just to digit 2 and just to digit 3 start to respond to both fingers. So I think it's a very similar sort of phenomenon where you have this merging of cortical representation fields. And so the question here is, can we link this neuroplasticity with behavioral deficits in carpal tunnel syndrome? So for example, why does it matter that you now have this blurring in your brain? Do blindfolded patients, for example, mislocalize D2 with D3 stimulation, digit 2 to digit 3 stimulation? And is this potentially then leading to some of their behavioral deficits, like fine motor control and some of the problems that these patients are feeling? So what we did is a follow-up study. So we wanted to look at questions such as this in the follow-up study. And we now included 8 weeks of acupuncture, a slightly longer procedure. And we also had a long-term follow-up, a 3-month follow-up for clinical outcomes. And we also had not just local acupuncture groups, as I showed you before, but we had a distal acupuncture groups where it was real acupuncture, but they were not treated at the wrist. They were treated at the opposite ankle. And this was then compared to sham acupuncture, which is something else that we didn't have in the original study. So for the sham acupuncture, we have these non-inserted needles called Streiberger needles, which look like acupuncture needles, and they look like they're going into the body, but actually do not penetrate the skin. And so we used these needles, and we used fake electroacupuncture, electrostimulation, so all the electrodes were set up to the needles, but there was no current that was being passed, and no needle that was being inserted. So first of all, why did we want to include the distal acupuncture comparison group? Well, it's kind of an interesting question. So with local acupuncture, you have this local sort of axon reflex, this increase in blood flow that's happening right at the site of the needle. Okay, and this is graded based on how deeply you insert the needle, whether you get this da chi sensation by manipulating the needle. And so there's more blood flow, and this is a potential mechanism of action for acupuncture that wouldn't necessarily involve the nervous system and the brain, right? So the brain then is just a readout for what's happening at the wrist. But with distal acupuncture, you couldn't make that argument because any sort of local effect is happening at the opposite ankle, not at the location of the wrist itself, where the lesion is in carpal tunnel syndrome. So interestingly enough, there is a reason to actually perform acupuncture on the opposite ankle. There's these systems called mirroring acupuncture systems where, let's say you were treating shoulder pain, you would actually treat the opposite hip, for example. Or for knee pain, you would treat the opposite elbow. So these mirroring systems do exist clinically. Nobody's ever really looked at these things scientifically. But we thought it was an interesting reason to include this as part of the study design. So this is our flow chart. We had 80 CTS patients that were randomized, and we got pretty decent retention all across our measurements and even into the 3-month follow-up where we had close to 20 patients for the groups, both at final and in the long-term follow-up. So for an imaging study, that's actually quite good. So first of all, baseline comparisons. These are now, of course, completely different CTS patients than we evaluated in the pilot studies. And we again found a contraction of the D2, D3 separation distance in the patients compared to healthy controls, which is really important. I'm sure you've heard there's a lot of publicity right now around replication and robustness of research. So the fact that we were able to replicate this particular finding, I thought was actually very important and very nice. And we did this replication not just with functional MRI, but also with magnetoencephalography, which is a different technology where we're looking at actual neuronal activity, not just hemodynamic response, which is what we're looking at with functional MRI. And so we again found contraction of D2, D3 separation distance with this other technique. So a different set of patients, much larger numbers than the previous pilot study, and also 2 different modalities that we were applying here to evaluate somatotopy in these patients. So another interesting thing is that we were able to, I think, finally say that this contraction in S1 is indeed maladaptive. So, it could be just a coping mechanism on the part of these patients in response to what's happening at the wrist. But in this case, what we were able to do is by doing this finger agnosia testing that I talked about before, where we actually blindfolded them, or in this case, we didn't have to blindfold them. We just put their hands over top of this vibrotactile device, and they didn't know they weren't looking at it, they didn't know what was being stimulated, but this vibrotactile buzzer was stimulating different fingers, and they were asked which finger was stimulated. So it was a whole procedure that we did behaviorally. And what we found is that CTS patients made mistakes more often than healthy controls for the fingers that were innervated by the median nerve, which is the second and the third finger, but not for the pinky, the ulnar nerve innervated digit. And what we found was that there was a correlation between the D2, D3 separation distance and the amount of mistakes that they make. So subjects who make the most mistakes on this test were the ones whose D2, D3 separation distance in the brain was most contracted. And so it's because of this that we were able to say that the altered somatotopy in S1 in the brain in these patients is indeed maladaptive. So interestingly, we also found not just functional plasticity in the brain, but in this study, we found structural plasticity. In this case, there was a reduction in the gray matter density in this location in S1 in CTS patients compared to healthy controls, which was interesting because it was also associated with the median nerve sensory conduction velocity. So in this case, the slower the velocity, the more affected is the patient at the wrist. And we found a correlation wherein the more there was a reduction in gray matter volume or gray matter density at this location in S1, the slower the velocity. And this was also kind of interesting because reduction in gray matter volume has been seen for other chronic pain disorders. This was one of the first reports by Abkarian's group in 2004 in chronic low back pain patients who found a reduction in dorsolateral prefrontal cortex in gray matter volume. But this is actually in contradistinction to what other groups have found in S1, in the primary somatosensory cortex, where actually chronic pain patients have an increase in cortical thickness or gray matter volume in S1. And there's other reports, too, showing that this occurs in primary somatosensory cortex. There's actually an increase in cortical density. And so the question is what's going on here? Why are we finding this decrease in S1, whereas other groups, other studies are finding an increase in S1 in chronic pain patients? And so we were kind of scratching our heads about this, and what we did is we actually looked at subgrouping our CTS patients. And there's people that have done this for symptom reports in CTS patients have found independent factors. So these factors load on to different sensations. There's a factor that is associated with more predominance of pain in these patients. And there's a factor that's associated with more predominance of paresthesias, sort of this numbness, these tingling sensations that the patients also feel. And so when we took our patients and we separated them into paresthesia dominance subgroups versus pain dominant subgroups, that's where we saw a really large difference, specifically in S1, where it was the paresthesia dominant patients who had less cortical thickness in S1 compared to the pain predominant CTS patients. And it just so happens that CTS patients are usually predominantly paresthesia dominant patients, not pain dominant patients. And so that's probably why we saw this decrease in S1 in the full cohort of patients that we reported previously. And this was interestingly correlated with the amount of paresthesia severity in the paresthesia dominant patients and also the amount of pain in the pain predominant patients. So those subgroups of CTS patients that were pain predominant, for example, actually had an increase, you can see that right here, an increase in cortical thickness in S1 and M1 with the amount of pain that they felt. So the more pain they feel, the greater the cortical thickness. whereas the opposite is true for paresthesia dominant. The more severe the paresthesia, the more reduction they have in cortical thickness. So that was really interesting. So coming back to the results in response to acupuncture in our larger follow-up study, what we found was that there was basically all three groups. First of all, there was no difference between distal and local Verum acupuncture, and so we grouped those together into a Verum group, CTS Verum group, for this BCTQ symptom severity outcome. And so in that case, there was actually no difference between any of the groups, whether they were Verum or sham, for the post-acupuncture time point compared to baseline. Everybody got better, basically. When we looked at the long-term follow-up, though, there was a difference where the CTS Verum group retained their improvement at the 3-month outcome, whereas the sham group did not. They reverted back closer to the baseline condition. And then this is the breakdown for the local versus the distal versus the sham acupuncture group. You can see that here, basically similar to what I just told you. So then, though, when we looked at objective outcomes, these are the median nerve conduction latencies that were also recorded in the NCS studies. Here we did find a difference between Verum and sham acupuncture. There was improvement following Verum acupuncture that was significantly different, and there was actually some worsening that happened in the sham group. So over time, these patients were actually getting worse if they were being treated by sham acupuncture. And so this is the breakdown. There was a stronger effect here, a stronger effect size for the local acupuncture treated group, but both groups were significantly different from the sham acupuncture group. So this was interesting, and again, sort of I think similar to the previous report I showed you about asthma, where the objective outcomes were superior for the Verum acupuncture condition, but not for the sham, whereas subjectively all three groups were getting better. So we also looked at the change in the mapping in D2, D3 separation, and here we found improvement, sort of an increase in the separation distance in the brain for the Verum acupuncture group and not for the sham acupuncture group. And this again was more pronounced, larger effect size for the local acupuncture treated patients than for the distal. And in this case, the statistical significance was only there for local acupuncture relative to sham acupuncture. And we also found a predictive capacity of this remapping in the brain. So in this case, the patients that improved, there was heterogeneity amongst patients. Some improved their mapping in the brain and some did not. Those that improved the mapping the most in S1 were ones who had the best outcomes in the symptom severity at the 3-month follow-up. So they retained the most in the most outcomes. So it's good to remap your brain. If you remap your brain, you have more longevity of the effect of the acupuncture. It persists for a longer period of time, which is interesting, and it shows kind of the clinical relevance of this brain mapping outcome that we identified here. So there's obviously, more research questions that we need to look at. We want to differentiate local and distal acupuncture effects and look at S1-based mechanisms. And so, why are both of these getting better? Is there potentially different mechanisms by which local and distal acupuncture is working for these patients? So in this case, we actually did something a little bit different, and we looked at not the gray matter and the functional activity in the neurons, but we looked at the white matter that's just below where the gray matter is. So these are the pathways that are feeding afferent information up to these neurons that's located in the gray matter. And so here we have a different imaging modality that we're looking at called diffusion tensor imaging, or DTI. So if you allow me for a second, I'll talk a little bit about what this is if you're not familiar with it. So basically, this imaging technique allows us to map the diffusion in the brain. So if you can imagine, for example, a cup of water, any particle within that water is moving equally in all directions. This is Brownian motion. And so if we look at the diffusion, it's identified as isotropic diffusion, meaning it's equal in all directions. And there's a parameter that looks at how much diffusion is happening in different orientations, and that's called FA, or fractional anisotropy. So here there will be low FA, or low fractional anisotropy, because water is going equally in all directions. And if we contrast that to, let's say I put a straw inside of this cup of water, and I look at a particle of H2O inside of that straw, now there's going to be barriers. That particle cannot go through the plastic of the straw, and so now the diffusion is happening more readily along the longitudinal dimension of the straw, and so this is a condition that has high FA, or high fractional anisotropy, and anisotropic diffusion. And in fact, it's this condition that's happening inside of the white matter, because the white matter are these pathways that are surrounded by myelin, and the myelin sheath does not allow water to penetrate as readily as it does along the fiber, the axis of these white matter fibers. And so this is a way that we can pick up and study the fractional anisotropy, or the sort of the integrity of the white matter in different parts of the brain. And this has been done a lot. So, for example, in stroke and other brain disorders have used this technique a lot. And so what we did is that we really focused on not just anywhere in the brain, but in the white matter pathways that are feeding S1, the primary somatosensory cortex, which is what we were really focusing on. And so what we found when comparing CTS patients with healthy controls is that CTS patients have greater fractional anisotropy, greater FA, in specific white matter pathways feeding different body areas. So for example, this is related to the contralesional hand area. We found a greater FA in the white matter that's just adjacent to this area. But we also found other areas too. There was the ipsilesional hand area. So this is ipsilesional to the lesion on the wrist. Now keep in mind, a lot of these patients have bilateral CTS. So we were treating their most affected hand, but actually a lot of them also had what would qualify as CTS on the other hand as well. They were bilateral CTS patients. So it's ipsilesional to the most affected hand, but it still could be contralesional to another hand that is affected. But interestingly enough, we also found this other cluster that was located on the ipsilesional leg, which was a little bit surprising, but also, could this be somehow related to why mirror styles of acupunctures are working, specifically in this disorder? Kind of intriguing and purely speculative, but interesting. So, is increased FA in CTS, is this related to enhanced white matter myelination due to aberrant afferent signaling? So there's a greater amount of afferents than coming through from this area of the, of the body, from the hand, and it's diffuse, and is this then changing the myelination patterns of the white matter fibers that are leading to this part of the brain? And is altered fractional anisotropy in ipsilateral leg region related to efficacy of distal EA for carpal tunnel syndrome? So again, the contralesional hand corresponds to the CTS lesion at the wrist and is activated by local acupuncture, whereas the ipsilesional side, we know then, is deactivated by the acupuncture procedure. This was a different paper where we actually looked at brain response to the acupuncture procedure itself, finding activation contralaterally to the electroacupuncture stimulation and deactivation ipsilaterally. And also when you stimulate on the leg, on the ankle area, you get, of course, activation contralaterally in S1 to the location that you're stimulating. In this case, it's a very different part of S1. This is kind of the ankle area, if you will, of S1. And so what we found is that there was this interesting dissociation where improvements in FA after the acupuncture were associated with improvements at the wrist in nerve conduction latencies that were specific for different treatment styles. So whereas for Verum acupuncture, the improvements at the wrist were associated with improvements in FA in the contralesional hand area. So this is the area that's associated with the wrist itself. But for local acupuncture, the improvements on the ipsilesional side were associated to improvements at the wrist. And that was the case only for local acupuncture, not for distal acupuncture and not for sham acupuncture. Whereas if we looked at this location, on the that's associated with the ankle, and we looked at the change in FA there, changes here were associated with improvements in the wrist only for distal acupuncture and not for local acupuncture or for sham acupuncture. So it's this specificity in S1 that's associated with these different treatment styles, and was, to me, was very surprising and I think really interesting and something we need to follow up on in future studies. So the model for how this is working is that whereas local acupuncture might be working by both local mechanisms, so again, this like axon flare, this increase in blood flow at the site of the needling, it also could be working through sort of this ipsilesional S1 hand area and through these brain-based mechanisms. So we shouldn't restrict the sort of the mechanisms of acupuncture as just being local to where the needle is going in. And that's certainly the case for distal acupuncture, because if distal acupuncture is working for carpal tunnel syndrome, it must be working, I would argue, through the brain and through these mechanisms of rewiring brain circuitry. So in the future, we want to determine sort of the temporal order of these things. Are the local changes preceding the changes in brain plasticity or vice versa? What's driving what? I think that's an interesting question for the future. And this is just a kind of a little animation for what's, what we just saw, just to review that, in carpal tunnel syndrome, you have this contraction of D2, D3 separation distance, due to this aberrant firing. And then when we have electroacupuncture, is then that overriding this like aberrant firing that's happening, across the median nerve, and it's this regulated firing that's then serving to increase the D2, D3 separation distance, over the median nerve. That's kind of our potential model for what's happening with electroacupuncture. So in summary, this was really a kind of a long road, and so for those of you that are engaged in research, the name of the game is persistence. And this study really started when I came on as a postdoc, back in 2001 and 2002, and started engaging in this pilot study. And the results of that pilot study weren't really published until 2006 and 2007. We got our R01 funding for the follow-up longitudinal study back in 2008, 2009, and it's only just a few months ago that this final paper was published with the longitudinal results. So it really is a long time for this stuff to come out. So yeah, the take-home message here is that both Verum and sham acupuncture improve subjective psychological outcomes, while only Verum acupuncture can improve objective physiological outcomes, the nerve conduction velocities and latencies, D2, D3, cortical separation, these types of things. So, neuroimaging biomarkers for chronic pain, I think, it's important to think about, why do we want to look at, we have somebody that's, coming to us as a patient. They're reporting, they're not coming to us because their brain got rewired, right? They're coming to us because they're feeling pain, they're feeling paresthesias, numbness and tingling, at their wrists. So what is the role of these objective outcomes, these brain-based outcomes? And so, there's definitely some pros. We can better understand mechanism through these things. We can better understand therapies by understanding the mechanisms. It might be, as I just showed you, very important to include these types of outcomes in clinical trials, in longitudinal trials to understand mechanisms, because this is the way that different, maybe integrative therapies might be more accepted, is that if they show that there is not just a subjective improvement, but objective improvements as well. And that's something important, but actually using these outcomes have not just pros but cons associated with them, because if we were to use things like neuroimaging outcomes as a validated test, for example, for chronic pain, there's potential for false negatives, patient trust issues and denial of therapy. Let's say, insurance companies only want to provide coverage for a certain disorder if you have this brain-based outcome there. We could see that potentially down the road. That has a lot of strings attached to that. And, I think a lot of us neuroimagers, really caution the clinical community and the legal community and policymakers, around the use of neuroimaging outcomes for this types of purpose. So acupuncture, in summary, also particularly electroacupuncture, where you have electrical current that's associated with the needling, could be considered a somatosensory guided neuromodulatory therapy, and I think fits very nicely with this interesting push for electroceuticals. And there's a lot of pharma companies that right now are, starting divisions for what they're calling electroceuticals, which is basically just electrical current that's being projected. TENS is an old version of this, and there's some rebranding that's going on right now in the community. But I think electroacupuncture falls very nicely into this fold. And also local versus distal acupuncture might improve peripheral nerve function by somatotopically distinct S1 neuroplasticity. And could this potentially be the basis for acupoint specificity? At least a very crude form of acupoint specificity, where different body areas, it might be important to needle different body areas because of their mapping in S1. So definitely, I want to thank all my team in this, without whom this definitely would not be possible. And Norman Kettner, Joe Audette from Spalding, who were very much involved in the design of these very early studies and were my mentors back in 2002 and continued along with this research. So I want to thank them all. And thank you for your attention. If you have any questions, I'm very happy to answer. Gary.
Drinking from fire hose, huge amount of data, great work. When you do the nerve conduction studies, is it working? When you do the nerve conduction studies, are you looking at primarily or exclusively large myelinated fibers, or can you pick up the small fibers that might be more related to the pain phenomena?
Yeah, that's a good question. I think because it's like a compound action potential, it might be picking up multiple, but it's most likely to be the large myelinated fibers that are being tracked because those are picked up first. And typically it's not, sometimes it's a painful procedure to go through the EMG, but with surface EMG, it's usually not a painful procedure. And so it's most likely to be the large myelinated A beta fibers that you're really picking up.
Vitaly, really wonderful presentation. Thank you. I was really struck by the differences in what was going on in the brain between the local versus the distal stimulation, as well as proximally. And just thinking about this from a clinical acupuncture perspective, where needles are typically put in multiple locations, I think it's really just kind of fascinating that the field sort of evolved in this way that to stimulate multiple things in the brain and physiologically to promote optimal healing, if you will. And I wonder how much of that we lose sometimes by trying to really standardize or simplify acupuncture interventions in clinical trials. Any thoughts?
Yeah, that's a great point. And I think one other message to get across is the point is not to say what is superior, local acupuncture or distal acupuncture. The point is that these might be working by different mechanisms, and you probably want to combine them. You probably want to, when you're actually treating somebody in a clinic, you want to do both local and distal acupuncture, which is actually done a lot for a lot of different disorders where you're maybe needling locally to where the patient is reporting the problem, but also distally away from that area. And depending on the disorder, whether it's low back pain or migraine, it might be the local or the distal that's most effective for that disorder.
Great presentation, and congratulations. I have a question for you. Is that when we see the patients improve objectively as well as subjectively, if they improve both of them, does that mean that clinically they actually have a longer, much lasting effect, and then compare with patient only improving in the subjectively?
Well, if they're improving subjectively, then they have a long-lasting effect. Right? If we're saying long-lasting effect,
yes, so
probably we're talking subjectively whether it's a long-lasting effect. That's how we know that, from the patient standpoint, that they're feeling better. So, because we had the link between objective improvement immediately after the therapy and the long-term follow-up, and the subjectively, the two are inexorably linked. They're not just happening remotely, which is a good thing because we're trying to get at mechanisms for why people are getting better. So I think they are linked, and I think it is important that they're improving objectively. I don't know if that answers your question.
No, I mean is that if you see the group of patients only improve subjectively versus the group of patients that improve both subjectively and objectively, so what's the long-term results in this between these clinical outcome between these two groups? I assume that I don't know if that's true, but I assume that patients who are improve objectively as well as subjectively, this group of patients probably have a much longer or lasting persistent improvement eventually versus patients that only improve in the subjective reporting.
We didn't subgroup it that way. We looked at associations, right? So we didn't subgroup it into responders and non-responders. But I think what you're asking would require a recategorization like that. But because the outcomes were related, were associated, those that improved in objective outcomes also improved in subjective outcomes, it's probably going to be more difficult to find a subgroup that, say, improved subjectively but not objectively, because the two outcomes are linked. They're correlated.
But that's I think will be interesting for us to looking in the future, because I assume that there might be some difference, so that actually gives the reason that why we're looking for this, the objective markers, or
right.
Except that despite we have looking at the mechanism, but also maybe it's relevant to the long-term clinical outcome as well.
Yeah, in our study they were correlated, but it's actually a good point. In much larger studies like RCTs with Carpal Tunnel Syndrome, a lot of times the objective outcome, in this case the objective outcome is the nerve conduction velocity or the latency. The nerve conduction latency is not correlated with symptom report. So a lot of times they have very poor nerve conduction latencies, but their pain and the paresthesia that they're reporting is not very high, and vice versa. So there sometimes is this discordance in published reports. In our case, it wasn't. In our case, they were linked.
Thank you.
Thanks, Vitaly. Thank you actually for that wonderful explanation of fractional anisotropy. I don't think I've ever really understood that. So my question actually was about your cautions in terms of the false negatives and false positives that you said at the end. And I was just wondering, what's your sense of that sensitivity and specificity of sort of these neuroimaging techniques in general? It's what's the the magnitude of that risk?
Yeah, I mean, so far it's not great. So far, I mean, when you look at, so there was a paper in New England Journal of Medicine that reported a really high sensitivity specificity for brain response outcomes, but that was for an evoked pain. So that was for comparing a heat stimulus that was reported as being painful versus something that was reported as being warm. I mean, that's a gross difference. And so there you can have sensitivity specificities in the 90 percentile range. But anytime people have tried to do this for clinical pain, it's in the sort of 70s or 80s. And, we're looking at it right now. We just finished a large study with low back pain patients, and we have some imaging outcomes there, and we're sort of playing around with that to try to improve that, maybe with combining, multiple imaging outcomes. So there's definitely people that are looking at this and trying to improve that, but it's not great. And if you think about this and you think about the fact that there's already instances where in a legal framework, like workman's comp and stuff like that, where in a court of law, people have brought in imaging outcomes to try to prove that this person is or is not in pain. I mean, that's really frightening, to me when you're talking about these levels of sensitivities and specificities.
There. A bit about mechanism and an experimental procedure in rodents, and possibly it was done in primates, and probably a couple of decades ago, so my age is showing, was to do an acute reversible denervation by locally anesthetizing a digit, and to look at responses all the way up the neuraxis, from dorsal column nuclei into thalamus and into brain. I think it was Dwight Chapin, something like that. And so parallel inhibition, afferent inhibition where you get surround inhibition and things like that, changes the receptive field distributions acutely and reversibly. It's kind of the opposite of what's going on here, where you have ostensibly increased afferent activity, which might blur those boundaries, possibly account for, although we're talking about long-term versus acute, the change in distributions or separations in S1 between these regions. Hypothesis, speculation.
Yeah, I actually don't think that there's like axonal sprouting or something like that going on where you're actually like creating new connections that are not already there. It's the connections are there and they're just unmasked, masked and unmasked. The same way that you're saying was done with this lidocaine or with denervation type of experiment, where it's normally there's this inhibition of the, let's say it goes to the thalamus and then up to S1, and there's already connections from one finger to this cortical representation, but they're inhibited. They're not there through surround inhibition and other reasons. But then that connection is already it actually physically is there, but then is unmasked. When you now have diffuse paresthesias and afferents that's coming over. So now that connection, which already is there, is now more viable because of hepatic plasticity mechanisms and the such. So I think the same thing is happening here. And so this could turn off and on depending on the perception, depending on the symptoms and the afferents that these patients are experiencing. So in that way, I think it is a potential readout. But on the other hand, we know that S1 also has connections to, say, for example, autonomic control regions. And so it's these autonomic control regions that might then control sort of the diameter of the vessels around the median nerve and regulate the amount of blood flow. So maybe distal acupuncture is working in this manner by regulating the blood flow around the median nerve and dealing with the ischemia that's there, that's producing the carpal tunnel syndrome in the first place. So that's a viable option. I don't know of another option that it could be.
One question as a sort of for the clinical acupuncturist. Just one question I had was the acupuncture protocol may not, or the assessment of the individual may lead to different acupuncture protocols. So how did you resolve that? Because the assessment could be made and you may have two different ways of treatment. And how did you resolve that?
Right, that was the semi-standardized approach that we were using, where everybody got electroacupuncture in these two locations that we chose a priori. I mean, we worked with a senior acupuncturist in the very beginning, 15 years ago, to create this local protocol. And so everybody got electroacupuncture in these two locations, but then the acupuncturist could choose from a series of like 5 or 6 points, depending on the individual presentation. I mean, it just so happens that for something like carpal tunnel syndrome, there's not such a large heterogeneity. It's not like fibromyalgia or other disorders where you really could be treating something radically different from a TCM point of view in one patient versus another patient. For carpal tunnel syndrome, it's more straightforward.
And were you able to show or look at the differences, like how many patients got this constellation versus this
constellation? That's interesting. No, we haven't looked at that. I mean, it's all recorded, of course. We haven't looked at that. I mean, we should maybe look at that and look at if there's outcomes that are, better in one treatment style versus another treatment style within the local group. And yeah, it's a good idea.
Okay. We'll take one final question.
Thank you for your research. I wonder, in your study, any subject never responds to acupuncture or even getting worse? And what happened with this subject if that happened?
Yeah, I mean, there's definitely, whenever you do a study, there's going to be some patients who get worse no matter what the therapy is. And let me see if there's like a plot that could illustrate that. Maybe not. Maybe everybody got better. Maybe let's look at this plot here. So, what happened to that patient? I don't know. For the most part, you look at, let's say look at the y-axis and you look at the BCTQ, the Boston Carpal Tunnel Syndrome questionnaire scores at 3-month follow-up versus baseline, and even for Verum acupuncture, you do see people who are getting worse. why they're getting worse, for any one individual subject, I don't know. It could be because their brain is not being remapped properly. It could be for other reasons as well. Any one patient in a clinical study, that person could have been in a car accident in the middle of the study. That person, other things might have happened to that person in the cycle of the multiple months that they were in that study, and it's really hard to say anecdotally for what's going on with any one subject. But if you have, it's just what happens with neuroimaging studies a lot of times is that the ends are so small, it's really hard to subgroup that way. Because here we have 3 subjects who got worse, right? 3 subjects. There's very little you can say with 3 subjects. So that's why we need sort of larger sort of clinical studies, maybe that don't have the imaging outcomes, to try to understand what's happening with those people. Yeah.
Thank you, Vitaly. This
Thanks.
has been a great presentation.